What the Study Says.
Welcome back to What the Study Says. I'm Dr. Kai.
And I'm Dr. May. Today, we're tackling a disease that many of us, maybe optimistically, thought was sort of a fading memory, a relic of the past.
Right.
But alarmingly, it's making a very unwelcome global comeback. And it's not just, a childhood rash. It's a cunning, incredibly contagious virus with really serious and often surprising long-term consequences. And it is spreading rapidly across the globe right now.
Absolutely. We are talking about measles.
Yeah.
And our deep dive today pulls directly from a brand new, very relevant review article. It's just published this year, June 25, 2025, in the authoritative New England Journal of Medicine.
Mm-hmm.
It's titled Measles 2025, and it's a critical piece by Dr. Lian Anha-Du and Dr. Kim Mulholland.
And our mission today is really to unpack the crucial information from this study, understand its profound implications for public health, and, well, equip you with the essential knowledge you need to be truly well-informed about this evolving, pretty urgent situation. So what are the key takeaways you absolutely need to know?
Okay, let's jump right into the core issue.
Mm-hmm.
Measles isn't just contagious. The article reveals it's exceptionally contagious. We're talking a single infected person potentially spreading it to 12 to 18 others.
It's a staggering number.
That's a huge reproduction number, often making it one of the most transmissible diseases out there. So what's fundamentally driving this rapid resurgence right now, especially through 2024 and into 2025?
What's truly fascinating and frankly concerning here is how the article clearly pinpoints two primary culprits behind this global resurgence. The first major factor, it's the disruption of local immunization programs worldwide.
Ah, the pandemic effect.
Largely, yes. A ripple effect from COVID-19. Think about all the resources that were diverted, the campaigns paused. And second, we're seeing a growing global vaccine hesitancy.
Right, that's a big one.
And this toxic combination has led to a dramatic and dangerous reduction in measles vaccination coverage, creating these vulnerable pockets in populations.
And the numbers from the source are quite stark, really put that into perspective. The WHO reported nearly 400,000 lab-confirmed cases in 2024 alone.
Almost 400,000.
And in just the first 2 months of 2025, we've already seen over 16,000. What's especially sobering is that over half of those cases needed hospitalization.
Which strongly suggests the actual number of infections is far, far higher than what's being officially reported. Like the tip of an iceberg, really.
Exactly. Given how fast it spreads, let's dive into what measles actually does to the body, because it's far more insidious than just a childhood rash. For those who might only know it from pictures, what does classic measles look like?
Right.
From onset to recovery, and crucially, what are the less known, really serious complications?
Okay. So the illness typically begins quite subtly, about 10 to 14 days after exposure. There's a phase, lasts maybe 2 to 4 days, where it often just mimics a common cold. You'll see a fever and the classic 3 Cs, a persistent cough, coryza, that's a really runny nose, and conjunctivitis, so red, watery eyes.
The 3 Cs. Got it.
Now, here's where it gets truly interesting, diagnostically speaking, and often missed. Koplik spots. These are small, distinctive white spots inside the mouth, kind of like grains of salt on a red background.
Inside the mouth.
Yes. They are unique to measles pathognomonic, we call it, but they aren't always present. They often appear just a day or two before the main rash, a crucial early sign.
Oh, okay.
Then, the signature red maculopapular rash appears a few days later, usually starts on the face, behind the ears, then spreads downwards to the trunk and limbs. But what's critical for containing outbreaks is this. Individuals can transmit the virus for a full 4 days before that rash even shows up.
4 days before. Wow.
And for another 4 days after it appears.
That extended contagious period, especially before anyone even knows they have measles, that makes it incredibly tricky to contain, doesn't it?
It really does.
And the article stresses this isn't just skin deep. It's a systemic infection affecting many parts of the body.
Exactly. While things like diarrhea can appear early, maybe even linger for a month, the more severe complications, and these affect roughly 30% of cases, often persist for up to a month after the initial infection.
30%, that's high. What kind of complications?
We're talking bacterial superinfections like pneumonia. That's a leading cause of death in kids with measles otitis media, painful ear infections, and worsening conjunctivitis. And beyond those common ones, there are rarer but potentially fatal complications like severe pneumonitis and giant cell pneumonia. These are particularly devastating for, say, immunosuppressed individuals and very young children.
And the source highlights something called immune amnesia. It suggests the problems don't end there. Even after someone recovers, What exactly is that, and why should we be so concerned?
Right, immune amnesia. The broader implication here, and it's a deeply concerning one, is that the measles virus can essentially deplete specific immune cells that remember past infections, your B cells and T cells.
So it affects memory for other diseases.
Precisely. It's like partially wiping your immune system's memory bank. This temporary immune suppression, it can last for up to a year, maybe even longer.
A year.
Yes, leaving patients highly susceptible to serious secondary infections, especially bacterial pneumonia. The article points out that even in high-resource settings, like Germany, the risk of pneumonia after measles was significantly higher.
Wow.
And in low and middle-income countries where resources are scarce, the mortality linked to this hidden vulnerability is substantial. So a vital question this research prompts is, what strategies can we use to help restore immunity more rapidly? How do we prevent these delayed, devastating effects?
And the neurological complications. The article mentions some truly frightening ones appearing years later.
It does. Measles-associated encephalitis, while rare, is very serious when it occurs. It can strike acutely during the infection itself. Then there's something called measles inclusion body encephalitis, or MEBE. Yeah, it appears a few months later and, tragically, has a 100% mortality rate. And perhaps most frightening is SSPE, subacute sclerosing panencephalitis.
SSPE.
This can emerge years after a seemingly full recovery. Also 100% fatal, usually within 1 to 3 years of onset. And young children infected with measles, especially those under 2, are at significantly higher risk for this late, devastating complication.
That's just terrifying. The article also describes atypical and modified measles. Can you quickly clarify those? Why do they matter today?
Sure. So atypical measles was a severe form, mainly seen back in the 1960s. It happened in kids who got an earlier inactivated measles vaccine.
The old one.
Right, that caused an unusual rash, often starting on the limbs, and led to severe pneumonia. Thankfully, it's rarely reported now because that specific vaccine was withdrawn quite quickly.
And modified.
Modified measles, though, is relevant today. It's basically a breakthrough infection. It can occur in fully vaccinated individuals. This might happen because of primary vaccine failure, where the body just didn't mount a strong enough response initially.
It didn't take.
Sort of, yes. Or it could be due to waning immunity over time, often 6 or more years after vaccination. The good news is these cases tend to be much milder. Less fever, lower viral load, which means they're also less likely to transmit the virus.
Okay, so milder, less transmissible. That's somewhat reassuring.
It is. It shows the vaccine still offers significant protection, even if immunity isn't perfect forever.
Now, when outbreaks do occur, who are the most vulnerable? Who faces the highest risks?
Measles outbreaks disproportionately hit immunocompromised individuals. Think malnourished children, people with HIV, cancer patients undergoing treatment.
Right.
The source gives a really sobering example from China involving pediatric cancer patients. Even those who are vaccinated experience severe outcomes, including deaths. It's a stark reminder of how unforgiving this virus can be when the immune system is weak.
And malnutrition, you mentioned that link.
Yes, there's a historical and deeply intertwined link. Malnutrition worsens measles severity, making complications more likely. And measles itself can cause severe malnutrition, creating a vicious cycle. It's a major contributor to fatalities, responsible for maybe up to 45% of fatal cases in some settings.
45%?
Yeah.
Wow. And what about pregnant individuals? What does the article say there?
Good question. While measles isn't teratogenic, meaning it doesn't directly cause birth defects in pregnant people, it significantly increases the risk of fetal loss, intrauterine growth retardation, and premature delivery.
So serious risks for the pregnancy itself.
Absolutely. Preterm birth is reported as the most frequent fetal complication, and the case fatality rates for the pregnant individuals themselves can be alarmingly high. Maybe 5% in endemic areas, but potentially a devastating 20 to 30% among fragile populations like refugees.
Okay, given all these really serious risks, let's pivot to our defenses. What are the current recommendations for measles vaccination, globally and here in the U.S.?
Well, the measles vaccine has an incredibly long, safe, and effective track record. Decades of use. The recommended age for the first dose, it kind of depends on how quickly maternal antibodies fade and the local exposure risk.
Makes sense.
In countries working towards elimination, it's typically given between 12 to 18 months. That timing gives the best chance for a strong immune response. But it does leave very young infants susceptible during that first year.
Right, that gap.
In endemic areas where risk is higher, it's often given earlier, maybe at 9 months, sometimes even as early as 6 months in specific high-risk situations. The WHO strongly recommends a second dose for all children globally. That's key for ensuring robust, lasting protection. There should be at least a 4-week gap between doses.
And here in the U.S.?
In the U.S., the first dose is recommended at 12 to 15 months and the second dose between 4 and 6 years old. There's also advice for an additional dose for infants aged 6 to 11 months if they're in an outbreak area or traveling internationally.
Okay, so pulling this all together, what does this really mean for preventing community spread effectively?
It means that because measles is so incredibly contagious, remember that our knot of 12 to 18, achieving and critically maintaining very high vaccination coverage, is non-negotiable. We're talking at least 95% coverage with both doses.
95%, that's a high bar.
It is, but it's what's needed for effective herd immunity. Without hitting that extremely high threshold consistently across communities, outbreaks aren't just possible, they're pretty much inevitable.
And how are we doing on that crucial front? Are we hitting that 95% mark consistently?
That's a significant challenge globally and even locally. The source highlights several barriers. There's the growing global vaccine hesitancy, of course, but also financial barriers, poor access to healthcare in many regions.
Logistical issues, too.
Exactly, and even inappropriate medical contraindications sometimes being applied, preventing vaccination when it would be safe. It's a complex web. And even when overall national coverage looks good, small, interconnected, poorly vaccinated communities can still trigger widespread outbreaks. We saw that in the Netherlands example in the paper. It shows the problem is often localized vulnerabilities, not just the national average.
Right, those pockets of susceptibility. Beyond routine vaccination, what about after someone's potentially been exposed? Are there immediate steps?
Yes, that's where post-exposure prophylaxis, or PE, comes in. If someone is unvaccinated or maybe only had one dose, the measles vaccine itself is recommended within 72 hours of exposure. It can sometimes prevent illness or make it milder.
Okay, vaccine within 3 days. What if they can't get the vaccine?
Right. For those with medical contraindications like immunocompromised individuals, pregnant persons, or infants under 6 months, human immune globulin, or HIG, is recommended.
Yeah.
That needs to be given within 6 days of exposure.
HIG. That's antibody-based.
Correct. It provides passive immunity, temporary protection. HIG offers greater short-term protection in these groups, but it's more costly and often less available, especially in low and middle-income countries.
And there's a note about HIG itself.
Yes. A subtle but important detail. The article notes that the actual antibody levels in HIG products are decreasing over time. This reflects lower circulating measles antibodies in the general donor population because of successful vaccination programs in the past. It means we need to periodically review the recommended doses to ensure they're still effective.
Interesting knock-on effect. Okay, so is there an antiviral medication for measles? Or is it really just managing the severe fallout?
Unfortunately, no. There's no approved antiviral medication specifically targeting the measles virus itself. Management focuses entirely on early detection, swift treatment of those complications we talked about, like bacterial pneumonia or ear infections, and strict patient isolation to prevent further spread.
Isolation is key.
Absolutely. But one critical aspect of management, particularly in certain settings, is vitamin A supplementation.
Vitamin A. That came up earlier with malnutrition. But how does it fit into general treatment? Feels a bit unexpected for a virus.
Yeah, it might seem so, but what's crucial to understand here is that vitamin A deficiency has long been strongly associated with severe measles and increased mortality, especially in low and middle-income countries.
Okay.
Large trials back in the 80s and 90s definitively showed that giving vitamin A supplementation reduced measles mortality by a remarkable 34 to 50% in children.
34 to 50%? That's huge.
Massive impact. This led the WHO to recommend it for all acute measles patients since 1993, with specific doses based on age, regardless of whether they seemed malnourished or not.
Okay, standard practice in many places then. But the article brought up an interesting point about the U.S. context and some worrying misinformation around vitamin A. That seems like a really important distinction to make.
That's absolutely right. While severe vitamin A deficiency is relatively rare in developed countries like the U.S., the study notes that children hospitalized with measles in the U.S. frequently have low serum vitamin A levels, and these low levels correlate with how severe their illness is.
So even in well-nourished populations, it's relevant.
It appears so, suggesting a potential role even there. But this leads to a vital question. For generally well-nourished children, what's the clear guidance? The article highlights recent, quite alarming cases of vitamin A toxicity in the U.S., notably in West Texas.
Toxicity from taking too much.
Exactly. These cases were directly linked to excessive unsupervised intake. Why? Because of dangerous misinformation suggesting that high-dose vitamin A prevents measles, which it absolutely does not.
Right. It's for treatment of diagnosed cases, not prevention.
Precisely. This starkly highlights a critical need for clear, unambiguous guidance for both the public and healthcare workers on the appropriate use of vitamin A supplementation for measles patients. It's about supportive treatment during illness, not a replacement for vaccination or a way to prevent infection.
Okay, that's a vital clarification. So with all this information, let's zoom out again to the current global landscape. What are the key immunity gaps that are really driving this 2024-2025 crisis?
Okay, let's dive into the core of these immunity gaps. The first major one, and it's a big concern, is in very young infants. The protective maternal antibodies they get, from their mothers. They seem to be declining more rapidly over time than we previously thought.
So that protection wears off sooner.
It seems so. Studies show a significant proportion of infants are seronegative, meaning they lack sufficient protective antibodies by just 2 to 6 months of age. This makes them highly vulnerable, especially in outbreak regions, before they're old enough for their first vaccine dose under current schedules.
And the data backs this up.
Yeah, the data from 2023-2024 shows over 90% of global measles cases were in children in low and middle-income countries. And the highest mortality was in those under 1 year old. Vietnam, for example, saw a quarter of its recent measles cases in the 6 to 8 month age group.
Wow. Right in that vulnerable window.
Exactly. And these young infants face heightened risks for severe complications, including those devastating fatal ones like SSPE later on. This really leads us to consider, should the first vaccine dose be given earlier, maybe around 3 or 4 months?
But there are challenges with that.
Right. There's a potential issue of blunting, where giving it too early might interfere slightly with the immune response to later doses. So it's a complex balancing act for public health officials. Early protection versus maximum long-term immunity.
Okay, what about immunity gaps in adults? Do fully vaccinated adults need measles booster shots?
That's a common question. But for adults, the primary driver of resurgence is overwhelmingly a failure to vaccinate in the first place, or incomplete vaccination, not widespread vaccine failure itself.
So it's mostly people who miss shots.
Mostly, yes. The article clarifies that routine boosters for fully vaccinated persons are generally not recommended by the CDC or WHO. However, immunity gaps do exist, particularly in adults, say age 13 to 30, who might have received their doses under earlier, perhaps less effective vaccine schedules, or maybe only got 1 dose, or even received that old inactivated vaccine used briefly in the 60s.
So some specific groups might have weaker immunity.
Potentially. While some countries have offered a 3rd dose to certain cohorts, studies suggest the antibody boost from that 3rd dose can wane relatively quickly, maybe within 1 to 3 years. So the broader implication here, for most people, is that the focus really needs to be squarely on ensuring those crucial initial 2 doses are received and effective. Widespread boosters for already fully vaccinated people aren't seen as the main solution right now.
Got it. The article paints a pretty bleak picture of the current crisis, doesn't it? Pointing to factors far beyond just the virus itself. Sounds like a perfect storm.
It really does. We saw that dramatic global increase in measles cases from 2016 to 2019, fueled by large outbreaks and that growing vaccine hesitancy. Then the COVID-19 pandemic just hammered routine immunization programs,
Pushing coverage down.
pushing global first-dose coverage down significantly to 81% in 2021, the lowest since 2008. It has slightly improved, back up to 83% by 2023, but that's still well below the 95% needed.
And here in the U.S.?
Here in the U.S., as of May 30, 2025, the article states we'd already reported over 1,000 confirmed cases and, tragically, 3 deaths, with a staggering 96% of those cases occurring in unvaccinated individuals.
96%.
It puts us at very real risk of losing our measles elimination status, which we achieved back in 2000, if these outbreaks continue for more than 12 months. It's a really precarious situation.
And a crucial point the source makes, one that resonates so deeply and sadly, is the destructive role of misinformation, like that thoroughly, repeatedly debunked link between the MMR vaccine and autism.
Yeah, misinformation has become just a severe threat globally, relentlessly undermining confidence in life-saving vaccines. The article emphasizes, look, the claim that the measles vaccine causes autism has been rigorously investigated and comprehensively disproven for over 25 years.
25 years of proof.
Exactly. Yet its persistent shadow continues to cause immense harm. Furthermore, the article points out that withdrawal of U.S. support from vital global public health initiatives like the WHO and Gavi, the Vaccine Alliance, is predicted to have a profound negative effect on measles control worldwide.
Which circles back to us.
Absolutely. This situation, as the article reminds us so pointedly, puts our own domestic health security at high risk because, well, infectious diseases simply do not respect geographic borders. So, in conclusion, the article highlights a truly sobering reality. There's been, frankly, little substantive improvement in global measles control over the past 2 decades. The outlook is indeed quite bleak. And it's largely attributable to this declining global environment for health, where access to care is limited, where misinformation is just rampant, and where vaccine hesitancy continues to erode that hard-won public trust.
So what does this all mean for us, and what's next in this ongoing fight?
Well, the clear need is for enhanced research during outbreaks, a really concerted effort to address these pressing immunity gaps, particularly in infants, and of course a dramatic improvement in global vaccination coverage. But there's also some innovation on the horizon, which is good to hear. Rapid diagnostic tests could significantly improve our outbreak responses, and even new vaccine delivery methods are being explored, like microneedle patches.
The patches, yeah. Exactly. Pain-free administration, easier transport, especially in remote areas. That could be a game changer. And fascinatingly, the article even suggests evaluating a pneumococcal conjugate vaccine booster to potentially help overcome that temporary immune amnesia caused by measles.
Which could prevent those deadly secondary pneumonias.
A crucial idea. Really thinking outside the box there.
Which leads us to consider an important question, maybe for you, our listener, to mull over. While the scientific understanding of measles, its prevention, its treatment has advanced significantly, this ongoing crisis really reveals that the challenge isn't just a biological one anymore, it's a deeply societal one. How do we, as a global community, effectively bridge that gap between scientific knowledge and meaningful public health action? How do we ensure this highly preventable disease doesn't continue to devastate lives?
A powerful thought to end on. Thank you for joining us for this deep dive into the latest measles research. If you found this discussion valuable, please consider subscribing and maybe share this deep dive with others who might find it useful. Your support helps us continue to bring you these crucial insights. Until next time, stay well informed.